Hello, everybody. This is the last lecture for Pregnancy at Risk. Um, I'm adding this to our module. It's a very important topic. It is something that you may encounter frequently in maternity nursing as well as in other areas of healthcare, so we are going to talk about it. It does have implications for both mother and baby, for society, and for families as well. So just some background information to help you focus on this topic. Statistics are kind of fluid. They change. Most of them rely on a fair amount of self-reporting, which can be inconsistent. But a recent survey that was done in 2018 showed that 5% of pregnant women use at least one addictive substance, and about 7.2% of pregnant women report smoking cigarettes during their pregnancy. And that's the most recent information. However, other statistics point to increased incidence. It's all probably underestimated. And as we go through the different types of substances that people can abuse, you'll see some of those numbers are higher. It doesn't make sense that only 5% are actually using. That's the statistic for people who will disclose that they are using. Women with substance abuse very often do not get prenatal care, or they don't disclose their use to the providers because there is a stigma to using drugs while you're pregnant. If you think about it, there's a stigma to using drugs for a lot of people, but to use drugs while you're pregnant adds additional shame to that burden. And they have a very justifiable worry sometimes that social services, child protective services will come and remove the children from their home, not just the baby that they're pregnant with or that they just gave birth to, but also the other children in the home. So if they're not coming for care, we're also not screening them for diabetes, hypertension. We're not looking at fetal growth or well-being. We're not measuring their weight or their urine, looking for protein or ketones in their urine, all those things that we test for. They're not receiving the benefit of that care because they're too ashamed. They're afraid that they're going to get caught. And their fear is justifiable. Or even, believe the last number I read, and that was in 2019, was 13 states have enacted legislation that allows pregnant women to be incarcerated for the use of drugs. And these are very conservative states politically, and they take a punitive attitude, which you will find is of no real constructive value. Pregnant women don't get better in jail, and they are denied basic services. So that is not the most constructive approach if you look at the evidence, and yet it is a phenomenon that is happening. We also know that women who use substances, particularly people who report use of more than one substance, polydrug abusers, very often have a history of trauma, psychological trauma, and they benefit best from a non-judgmental, trauma-informed approach to recovery. And that means that we need to make them feel safe, and we need to avoid re-traumatizing them, and we need to allow them to process their trauma issues along with their substance use issues. Now I'm going to talk about a tool what SBIRT is. So SBIRT refers to the process of screening, brief intervention, and referral to treatment. And all women should be screened using an SBIRT type format with a standardized tool during pregnancy. So the way it goes is this. If you look at this graphic on the right side of the slide, phase 1, you establish rapport. You give the woman a non-judgmental, safe space, and you assure her that her results are going to be confidential. And then you administer a standardized screening tool, and you tell her, we give this to everybody. There's no wrong answers. Just please answer it honestly so that we know how to help you. When you get the results, if you get a positive screen, you are going to educate that patient about the health consequences of substance use in pregnancy. Again, not blaming her, not telling her what she should or should not do, just giving her the facts that if you continue to smoke, your baby may be small. Your baby may be early. There's a higher incidence of placenta abruption. If you are using heroin, your baby may go through withdrawal, and there are other health risks for both you and your child. Education in a non-judgmental format. Part of that can be eliciting information from them with a technique called motivational interviewing. And that involves exploring the issue and allowing the patient to really come up with the solution to the problem. So once they know that what can happen, you can say, "Can you tell me a little bit more about um, your drug use? I see that you report that you use cocaine. Can you tell me um, what are some barriers to quitting that use? What what kinds of things could help you do that? Have you thought about this? What have you tried?" So you kind of get the woman to talk about what may or may not work for her, so that you're partnering with her. And then we refer to treatment. That's where you negotiate a plan. And that treatment should involve a program that is especially tailored for the pregnant woman or the woman in early parenting. And it should include nutritional support, housing issues can be resolved. Really should address the woman's whole situation. If she's a victim of an intimate partner violence, you can address that, give her a safe place, um, along with whatever the treatment for the drug or alcohol issue is. Always look for comorbid conditions. One thing leads to another. If you are injecting heroin, you may have problems with infection or abscesses, for example. If you have alcohol abuse as part of your pathology, that kind of washes out all the B vitamins and can leave a woman in a poor nutritional state, which will also have consequences for her baby. But that's expert. You should know that. And now we're going to talk just briefly about each individual drug. So alcohol abuse, I put some key statistics here. There is a reference in the notes section of the slide. So about 20 to 30% of women, which is a lot, report drinking at some point during pregnancy. Typically, it's before they know they're pregnant in that first trimester, and then they quit. They abstain, which is the ideal thing. But more than 8% of women have reported binge drinking at some time during pregnancy, again, most typically in those early weeks where she may not know that she's pregnant. 10% of pregnant women report drinking alcohol in the previous month. It's a fairly high number. And almost 5% of pregnant women reported binge drinking in the previous month. So they knew they were pregnant and they had 4 or more drinks on that occasion. So this is a bigger problem than we know. It leads to the fetal alcohol spectrum disorders, the most severe and most well known of which is fetal alcohol syndrome. And this is a picture of a kid with fetal alcohol. The thin upper lip, the absent philtrum. You have widely spaced eyes, small eyes, and sometimes epicanthal folds. It has like a characteristic appearance, but we do miss a lot of alcohol use in pregnancy. It doesn't show up on standard, say, 12-panel drug screens, and it's metabolized by the body in hours. So more facts about alcohol abuse in pregnancy. No amount of alcohol during pregnancy is considered safe. You will need to know that. It is not necessarily dose dependent. So unlike cigarettes, where the more you smoke, the higher the chance you're going to have a low birth weight baby, some people can drink heavier amounts and their kids do not exhibit any problems. Other people will drink smaller amounts. It depends mostly on maternal and fetal genetics, how mom processes alcohol, how she metabolizes it, and then how the baby metabolizes it. It crosses the placenta very easily. And then environmental factors, if there's poor nutrition or if there's a lot of stress, you increase the likelihood of a fetal alcohol spectrum disorder. The incidence was very interesting, I found in my research. About 1 in 20 school-aged children, according to NIDA, National Institute for Drug Abuse, is suspected to have some type of alcohol-related issue, developmental issue. So it's a spectrum disorder, everything from alcohol-related birth defects, which may be a heart defect, all the way to fetal alcohol syndrome, which is the most severe, has behavioral cognitive deficits. These kids typically don't have good cause and effect reasoning. They may exhibit antisocial behaviors. They seem to not learn well. Um, so there's a range. The alcohol-related birth defects, like as I said, are isolated defects of one system, usually caused by a disruption, exposure to alcohol early in pregnancy and then embryonic phase. Mothers of children, so characteristics when they look at who gets FAS and who doesn't, and they compare those mothers, even though maybe both populations used alcohol. Um, to have a child with FAS, you are more likely to have poor nutrition. You are more likely to smoke. These women are generally shorter in stature and have lower BMI, so they're smaller. Maybe the alcohol kind of has a more toxic effect. They are more likely to be older, and they are more likely to be multips where they've already had other children. Um, so those are just some characteristics that might act as contributing factors to the development of fetal alcohol syndrome. You should make sure you're taking care of the whole woman, include nutritional supplementation, as well as referral to recovery programs. You may need to detox. Alcohol is one of those drugs. There are really only two classes of drugs that can kill you from withdrawal, and that would be alcohol and the benzodiazepines. Women can have seizures, they can go into DTs, and they can die, and so can their babies. So that's important to keep in mind. That it is not something you want maybe the mother to just necessarily quit cold turkey. That's why SBIRT is so important. Finding out as much information. Just saying don't drink might really not address this woman's needs. And also you're going to look at social issues. If they need housing, if they need protection from a partner who is violent, if they need any other sort of services, childcare for their other kids so they can go to recovery, uh, those things you would provide, and maybe refer to nutritional programs like WIC or SNAP. Okay, so now we're going to move on to opioids, and this is a big, big, big category. So we have seen a dramatic increase in the number of babies admitted to the NICU for neonatal abstinence syndrome. Opioids are a class of medications. They can be used for pain relief. Some of them are illegal. They don't have a therapeutic use. Think of heroin. Fentanyl's on the street a lot, and fentanyl is now being used to supplement heroin. It is much more powerful, creates much more of a tolerance, and increases the likelihood of withdrawal. And also your prescription painkillers. A lot of times that is how um, opioid abuse disorder starts. It can start as a prescription medication that is taken inappropriately for too long or in too large a quantity. And then the person starts to have withdrawal symptoms when they no longer have access. And then they might turn to heroin, fentanyl, street drugs. So it's a national health crisis. According to the CDC, their website, the incidence of opioid abuse in pregnancy has increased 131%. That's more than doubled between 2010 and 2017. And we were having a problem with it in 2010, to be honest. Opioid use disorder is associated with a lot of adverse outcomes. The biggest one, and you're going to hear more about this when we do high-risk newborn, is neonatal abstinence syndrome, which is a cluster of symptoms like high-pitched cry, sweating, watery stool, failure to be comforted, sneezing, yawning. But it's a cluster of symptoms that makes a baby just inconsolably miserable. And many babies who are exposed to opioids on a regular basis in pregnancy will experience them. Pregnancy loss from stillbirth or miscarriage is more common when opioids are abused. Um, and we'll kind of talk about that in a minute when we talk about opioid replacement. It isn't the opioid itself that impacts the pregnancy. It's all the lifestyle factors that go with it. Housing insecurity, food insecurity, intimate partner violence. Sometimes people turn to sex work and they're exposed to violence there. But there is a higher incidence of pregnancy loss with opioid abuse disorder. They can get sepsis because bacterial infections, cellulitis, abscesses, bacterial endocarditis, common when the drug is injected intravenously. They can be exposed to hepatitis or HIV from contaminated needles. Babies tend to have fetal growth restriction. Again, that is from the lifestyle factors that accompany the disorder more than it is from the actual opioid. Preeclampsia is much more common with opioids, and it can get more severe. Postpartum hemorrhage after they deliver, they are more at higher risk for bleeding, and fetal seizures in utero, which sometimes leads to fetal death. The babies in utero will go through withdrawal, which is where I'm going to go with this next couple sentences. Treatment should be in a program specially created for pregnant and parenting women. There are many out there, but they are not enough to meet the need. Um, and they should include opioid replacement. Sometimes people think that that's just a legal way to get high. I assure you it is not. It prevents fetal harm. When babies go through withdrawal in utero and there's nothing you can give them, they can have seizures, they can have strokes, and they can die. So we want to prevent that. And we also want to get mom out of the environment where she maybe doesn't have good nutrition, maybe she's exposed to violence, maybe she's using other drugs along with the heroin. If we can get her into a recovery program um, that helps support her um, and tailors to her special needs, because even among drug users, if we send her to a standard recovery or treatment program, there's stigma even among drug users for pregnant women. If possible, we want to get mom clean and make her life as stable as possible so we can keep them together. That is the best possible outcome for the baby. Marijuana. Okay, moving right along. The use of marijuana during pregnancy has been increasing. Between 2003 and 2017, the rate of marijuana use that is reported by pregnant women has gone from 3.4 to 7%, and that is double. And from 5.7% to 12.1% in the first trimester, again, more than double. Um, True incidence is probably higher. There are probably a lot of women who are using, they have increased access. It's no longer a criminal thing in most states. Um, and they may not be smoking it, they may be getting edibles. Some women, actually, it's sort of a cultural thing, may self treat morning sickness and nausea with marijuana. They claim that it helps. However, there is no established safety data, and the preliminary data suggests that babies exposed to marijuana in utero have lower birth weight. They have lower like length measurements. They have neurological issues like impaired social interaction, cognitive and attention deficits, and abnormal response to sensory stimuli. They're hypersensitive to sound and visual stimuli. Um, so the best idea is to identify women who use medicinal marijuana. So what are you feeling or what's going on when you're using it? Oh, you have nausea. Well, marijuana doesn't have a good safety record with pregnancy, but we can talk to the physician or the provider about maybe giving you something else for nausea. And here are some things that aren't medicine that might help you. If they're taking it for anxiety or depression or pain, we should be looking into things that are safer for mom and baby. And I think this is our last slide. It is a collection of a few other drugs that you might encounter. Excuse me, that's not an exhaustive list. But MDMA or ecstasy might be more common in the younger population. There is not a lot of data on MDMA in pregnancy, and I don't even know the incidence of it. I could not find that statistic easily. But it is thought to cause problems with learning, memory, and motor development. It does so in lab animals, and studies of children under the age of 2 who are known to be exposed have a higher incidence of those things. Not known whether those are permanent changes or not, but at least for the age of 2, that has been found. Cocaine and methamphetamine are both stimulants, so they have similar effects on a pregnancy. You see intrauterine growth restrictions. So what they'll do is they'll cause the blood vessels in the placenta to constrict. That reduces blood flow to the baby and flow of nutrients to the baby. So the babies are smaller, and they usually have something called, and we'll talk about this a little bit more with the newborn, asymmetrical IUGR, intrauterine growth restriction. The heads keep growing at a relatively normal rate, but their bodies look very small and shrunken. And they don't usually have the length when compared to other babies their gestational age. They're usually a little shorter. You can see a lot of pregnancy loss from stillbirth, miscarriage. You won't see that in maternity nursing so much, but you might see in the emergency room. And that is from that effect when the blood vessels constrict very suddenly, especially with cocaine, and then they dilate again, and then you use again, and they constrict again. You can actually cause a placental abruption, which was in a previous video that you should have viewed. little bit ago, that actually the placenta will start shearing off. And as blood collects between the placenta and the uterine wall, that shearing effect gets bigger until the placenta is no longer attached. There's no source of nutrients and the baby dies. Placental abruption can also lead to maternal hemorrhage, as you should know from watching that video. Hypertensive disorders, again, you're causing vasospasm, and that's going to increase your blood pressure. It's a stimulant. It increases heart rate and blood pressure. Very often, it can lead to preterm delivery because the baby is so stressed. It triggers mechanisms for preterm labor. Or maybe mom comes in and she's having a hypertensive issue or a placental abruption, or there's IUGR, and the provider decides that it is safer for the baby to be out of mom than inside. And then lastly, neonatal death after the fact. Maybe you deliver the baby and you get a heart rate and breathing, but the damage is too much and they can't sustain life. So that is our lecture on substance use in pregnancy. I hope it wasn't too painful. It is super important to understand this topic and to understand the approach to dealing with women. All right, guys, till we meet.